Sleep is vital for everyone. It's the key to physical healing, memory, and emotional well-being. Without enough sleep, we are more prone to illness, bad moods, poor communication, and struggling with tasks like exams. Now, imagine how much more challenging this is for children with Autism Spectrum Disorder, or ASD, who already face significant social and communication challenges. Unfortunately, children with ASD experience sleep disorders, especially insomnia, at much higher rates than their peers, and the impact is profound. Insomnia disrupts their ability to adjust to daily routines, affects their mental health, and impairs both their academic performance and family dynamics. In this video, we will present the prevalence of insomnia in children with ASD, why it's such a big deal, and a promising treatment approach combining melatonin and cognitive behavioral therapy. But first, what is insomnia? Well, it is characterized by difficulty falling asleep, staying asleep, or getting good quality sleep. In other words, studies have found that autistic individuals presented with longer sleep onset latency, reduced sleep efficiency, and increased amounts of wakefulness after sleep onset. Insomnia has been identified as the most common sleep disorder among children with ASD, as it has been found to prevail in 40 to 80% of children with autism spectrum disorder, which is 2 to 3 times higher than their typically developing peers. Insomnia exacerbates symptoms of hyperactivity and repetitive behaviors in ASD populations, which leads to more impulsivity and even aggression in some cases. But the consequences of poor sleep extend even beyond behavior. Insomnia negatively impacts learning, memory consolidation, mood regulation, hormonal development, and physical growth. And the struggles aren't limited to the child alone. It ripples out to the whole family as well, with parents reporting high levels of stress, fatigue, and even burnout due to the constant vigilance required to manage their child's problems. Sleep deprivation can hinder the parents' or the siblings' ability to be emotionally and physically present, adding strain to family relationships. The role of melatonin. The secretion of melatonin is regulated by our body's internal circadian clock, specifically by a region in the brain known as the suprachiasmatic nucleus, or the SCN. This master clock helps align our internal rhythms with the natural 24-hour light-dark cycle. Under typical conditions, melatonin production ramps up in the evening and peaks during the night when it's dark, signaling to the body that it's time to sleep. Research shows that individuals with ASD often have lower levels of melatonin production at night compared to typically developing individuals. Studies using 24-hour monitoring of serum, which means in the blood, melatonin levels, have consistently found reduced nocturnal melatonin in individuals with autism, which can make it harder for them to fall asleep and stay asleep. Additionally, research shows lower levels of urinary 6-sulfatoxymelatonin, the primary metabolite of melatonin, indicating that their overall melatonin activity is reduced throughout the day. This deficiency in melatonin may contribute to an altered balance between homeostatic and circadian forces, possibly leading to an increased sensitivity to environmental stimuli. This may explain why children with ASD have difficulty with transitions. Studies have shown that melatonin supplements can help many children with ASD fall asleep faster and improve their overall sleep quality. Prolonged release melatonin, rather than immediate release, has proven especially effective not only at reducing sleep latency, the time it takes to fall asleep, but also lowering the number of awakenings throughout the night. Typically, doses start at 2 milligrams and can be gradually increased up to 10 milligrams if needed. While most children taking melatonin experience no major side effects, a couple reported mild issues like morning sleepiness or bedwetting. One randomized controlled trial study found that after starting melatonin, 25% of children no longer reported sleep concerns, and 60% showed substantial improvements in sleep quality. Also, recognizing that children with ASD may be reluctant to take medications directly, parents can easily administer melatonin in liquid, food, pill, or even toothpaste. But while melatonin can help with the transition into sleep, it does not address the underlying issues that make sleep difficult. For real, long-term improvement, a different approach is needed. This is where cognitive behavioral therapy for childhood insomnia, or CBTCI, comes in. Research shows the most successful outcomes arise from combining melatonin with CBTCI, which has been shown in meta-analyses to yield significantly better sleep quality than either treatment alone. CBTCI teaches lasting skills that help children develop and maintain healthy sleep patterns over time by addressing bedtime routines, creating a calming and tidy environment, and introducing relaxation techniques. These strategies help children with ASD establish and reinforce a positive relationship with sleep. It is crucial to involve caregivers in sleep hygiene education because parents play such an important role in shaping their child's routines and environment from an early age. And a little added benefit is that as parents learn about sleep hygiene, they can improve their own sleep as well. A key part of CBTCI is sleep restriction, a technique that limits the time spent in bed to help increase the body's natural sleep pressure. The goal is to initially limit bedtime to the amount of time the child sleeps, no matter how few hours that is. The child will associate their bed only with sleep, and bedtime can gradually be extended, eventually allowing for a good full night's rest. For children with autism spectrum disorder, creating a structured bedtime routine along with melatonin can be especially helpful. Children with ASD often have sensory sensitivities, making it harder for them to fall asleep due to issues with noise, textures, lighting, or temperature. A helpful bedtime routine might start 2 hours before sleep with the ingestion of melatonin, followed by guiding the child to a quiet, calm, organized bedroom where they feel comfortable. Including a relaxing activity, such as reading a bedtime story, can make the transition to sleep positive, reinforcing a healthy sleep pattern. More sleep will improve the child's well-being, reduce ASD symptoms, and greatly improve the family's lives. By addressing both the immediate sleep challenges with melatonin and building long-term sleep habits with CBTCI, this combined approach offers a path to better sleep and improved well-being for children with ASD as well as their families. While existing studies suggest that melatonin can help with sleep onset and CBTCI can establish long-term sleep habits, more research is needed to fully understand the long-term benefits, optimal dosages, and specific strategies for integrating these treatments effectively, specifically for children with ASD.